I'm Dr. Lana Nelson. For this segment, we're going to be discussing some of the basics of weight loss surgery, and then we're going to be talking about the gastric bypass and the gastric sleeve. Be sure to stay tuned for the entirety of the presentation so you'll be well informed whenever we have a chance to meet for your initial visit. Our program is primarily a laparoscopic program. What I mean by this is that the majority of our surgeries are done laparoscopically or with small incisions in the abdominal wall. More than 95% of our surgeries are done this way. The advantages for you as a patient are that there are fewer wound complications. The two areas that we see a reduction in wound complications are with the formation of hernias following surgery. The hernia rate after open weight loss surgery is as high as 30%. After laparoscopic surgery, this goes down to less than 1%. That's a huge advantage for you. In addition, the incidence of a deep wound infection or a serious wound infection is much less with laparoscopic surgery. Because the incisions are smaller, there is less pain, which leads to a faster recovery. If you are concerned about scarring or cosmesis, it is considered more cosmetic as it does not leave large visible scars on the abdomen. And the largest advantage for me as a surgeon is that I'm able to see things in the operating room on a very large screen with magnification. It allows us to shine light in small areas and see things in fine detail. So those blood vessels and nerves that may be very difficult to see by the naked eye are very, very easily seen when they're projected in high definition to a big screen. So how does surgery work? There's different ways that surgery helps people to lose weight. One way is by something called malabsorption. What we mean when we say malabsorption is that nutrients pass through your system without being completely absorbed. There's one procedure that works on malabsorption alone. This procedure is called the biliopancreatic diversion duodenal switch. Sometimes it's simply referred to as the switch. With this procedure, the surgeon goes to the end of the intestines and counts backwards, so there's a small amount of absorptive surface that is maintained. Because this procedure does confer a large amount of malabsorption, there is the possibility of nutrient deficiencies, and it does require much more intense nutritional monitoring. In addition, there are additional risks with the surgery itself, and therefore we do not offer this procedure in our program because I feel like the risk of the surgery outweigh the benefits for the majority of patients. We're going to talk next about a hybrid procedure. Gastric bypass is what we call a hybrid procedure, and it works by combining both restriction, which means the volume of food that you need to feel full is reduced, and malabsorption. Now, the biggest difference between gastric bypass and the procedures that work with malabsorption alone is that with gastric bypass, we go to the beginning of your intestine and count forward, so the majority of your absorptive surface is maintained. That being said, there is still an element of malabsorption, so there is a possibility of nutrient deficiencies, and this does require ongoing nutritional monitoring as well. There is a third category of procedures, and these are called the restrictive procedures. And with the restrictive procedures, the idea is that the volume of food that you need to feel full is reduced. Vertical banded gastroplasty is one type of restrictive procedure, and this was the most common restrictive procedure throughout the 80s and some into the 90s as well. But it's been abandoned by most surgeons today, and the reason why that is because of some of the potential side effects and the potential of the surgery failing after many years. The biggest difference between the vertical banded gastroplasty and the adjustable gastric band that we do today is in that keyword adjustable. Unlike the old type of gastric banding where a band was placed around the stomach, with the new type of banding, that band is adjustable after it's placed. We all know that there's no such thing as one size fits all, so after that band is secured around the stomach, the tightness or looseness of the band, therefore offering more or less restriction, can be adjusted. The gastric sleeve is a procedure which refers to making a long tube out of the stomach, and therefore it creates a smaller stomach and the food needed to feel full is greatly reduced. Now, some of the procedures also work by alteration of digestive hormones as well, and there are many complex interactions which occur that affect hunger and satisfaction, and it can affect things such as type 2 diabetes. And you'll notice that there are certain procedures that work with alteration of digestive hormones. Typically when we think about the adjustable gastric band, there is no alteration of digestive hormones, but there is more so with the other procedures. Now we're going to talk about gastric bypass, also called the Roux-en-Y or the RNY procedure. The first part of a gastric bypass involves making a small stomach pouch. This is separated from the lower part of your stomach, and it's about 5% of your current stomach capacity. We then go downstream in your small intestine and make a cut or a division in your small intestine. Where we make this division, I then bring this portion of your small intestine up to connect to your stomach pouch. So after surgery, whenever you eat, you have a sense of fullness with a smaller portion of food. Food then passes directly into your small intestine. There's not much absorption that takes place in the first part of your small intestine. However, downstream you can see in the diagram that we reconnect the portion of the intestine that comes from your stomach. This allows the digestive juices that come from your stomach, your liver, and your pancreas to meet up with your food downstream. The majority of the absorption of nutrients occurs after this point or further on downstream. It's referred to as a gastric bypass because we bypass the stomach and the first part of the small intestine. Now your stomach is still there, it's still functioning, it still lives, it just does not have direct contact with the food anymore. One thing that's very unique about the gastric bypass is that when we bypass the duodenum, which is the first part of the small intestine, this leads to an impact on the way that your body interacts with blood sugar. So for type 2 diabetics, there's an immediate change in the way that your body responds to blood sugar. There have been some studies that have suggested that the improvement or resolution of type 2 diabetes is about 90% after gastric bypass, and a lot of this has to do with the fact that we bypass the first part of the small intestine, which changes the interaction with your food and its communication to the liver, which is in charge of blood glucose release, and with the pancreas, which is in charge of insulin release. So some of the advantages of gastric bypass surgery is that it confers rapid, consistent weight loss. Most people will see a dramatic weight loss within the first 6 months after surgery, and this can continue to anywhere from 12 to 18 months after surgery. This weight loss is sustained, although some people may see a little bit of weight regain in the first 2 to 3 years after surgery. The majority of weight that they lose is maintained for the long term. It does have an immediate impact on type 2 diabetes. There's a high improvement in the obesity-related health problems as well, things such as high lipids, obstructive sleep apnea, high blood pressure, heartburn, joint problems, and all of those things that were discussed in an earlier presentation. One of the other things about gastric bypass is that it's one of the most long-standing procedures that is out there. It has been done in one form or another since the late 1960s, so we have a large amount of data as far as what happens in the long term to patients who have had gastric bypass surgery. Some of the disadvantages of gastric bypass are that it's considered invasive because there is some rerouting and division of the stomach and the intestines. Some people consider this to be invasive. There's also a possibility of something called dumping syndrome. And dumping syndrome is something that can happen with ingestion or eating foods that are very high in simple carbohydrates or sugars. As those foods show up into your small intestine, normally your small intestine is not used to being exposed to a high concentration of sugars. Those are normally broken down in your stomach before presented to the small intestine. So after gastric bypass, when those sugars show up in your small intestine, it causes a release of digestive fluids and enzymes into the small intestine to help dilute or break down the concentrated sugars. The side effect for you will be that you'll have intense abdominal cramping, dry heaves, cold sweats, diarrhea, nausea, vomiting. It is a miserable experience if you experience dumping syndrome. But the thing about dumping syndrome is that it will keep you away from things that you should not have been eating in the first place. It doesn't happen whenever you are eating healthy food choices. There is a possibility of nutritional deficiencies because of gastric bypass, and it does require a lifetime of supplementation. So even when it's 2 to 3 years down the road and you feel like you're making better food choices, that your weight is better, that your health is better, you still will need to continue to supplement with certain vitamins. There is a possibility of something called a marginal ulcer or an ulcer that forms between the stomach and the small intestine. And this is more common in people who resume smoking after surgery. And I say resume smoking because our program is a tobacco-free, smoke-free program. It also is more common in people who have to use non-steroidal anti-inflammatory medications or steroids. We're going to talk next about the gastric sleeve. With the gastric sleeve, what we do is we place a tube down the esophagus into the stomach, and this threads into the first part of the small intestine. We then use that tube as a guide to decide how big your stomach is at the end of the procedure. And basically what we do is we find the valve between the stomach and the small intestine. We back off this valve a couple of inches, and then we start dividing your stomach from the bottom all the way up to the top where your esophagus meets up with your stomach. The remainder of your stomach is removed. It's actually removed from all of its attachments, and it comes out through one of those little holes in the abdominal wall that we use for laparoscopy. This is the only procedure that we offer that is not reversible. That's because once your stomach is detached from its blood supply, it gets put in a jar, it goes to the pathologist, it can't be placed again. Now, the advantages of gastric sleeve are that there are no rerouting of the intestines. So for people who have a large concern about malabsorption, this may be something to consider. In addition, for people who have to take anti-inflammatories for arthritis, it may be a good alternative for those individuals who may not be able to take those medications after gastric bypass. There's also no foreign material or implanted device. And for patients who do not see the weight loss results that they want, there is the possibility of transitioning to a gastric bypass in the future. Now, some of the disadvantages of the gastric sleeve are that it's not reversible. There is a certain subset of patients that it worsens gastroesophageal reflux or heartburn. There's only a short amount of data available at this point. We have about 5 years worth of data that's being reported in the literature, and so far it does show to be a durable weight loss procedure. There are still some insurance companies which consider the gastric sleeve to be investigational, and therefore there are some insurance companies that do not provide coverage for this procedure.